It's 12:03. I think we can start getting started. Jeff, are you ready?
I'm ready.
Okay. So good afternoon. I'm Jason Cobb. I'm an associate professor in the Renal Medicine Division, but I'm on the Department of Medicine DEI Council and a member of the Sexual and Gender LGBTQ plus Affinity Group. And we are having our annual LGBTQ Affinity Group lecture. And I have the privilege of introducing Dr. Jeffrey Lentz. He's a second-year post-doctoral fellow in the Division of Geriatrics and Gerontology. Dr. Lentz earned his Ph.D. in sociology from Georgia State University and master's in sociology from Southern Connecticut State University and a bachelor's in human services from Post University. In addition, he earned 2 graduate certificates in counseling and gerontology from Post University and Georgia State University. Dr. Lentz is passionate about advocating for older sexual and gender minorities. He is currently working with Dr. Molly Perkins on her NIA-funded study. This study focuses on ways to improve understanding of the relationships between and among informal caregiver involvement, informal caregiver health, and quality of life of assisted living residents with advanced dementia at the end of life, and ultimately seeks to identify potentially modifiable factors at the individual assisted living and wider community levels associated with adverse outcomes. We'd like to thank Dr. Lentz for speaking today. I'd like to thank all of you for joining. And we are a Department of Medicine affinity group, and it's open to staffs, faculty members, trainees. So if anyone interested in joining our group, please please reach out to myself and Kia Dodd about joining. Thank you, Jeffrey.
Thank you, Jason, for that introduction. So again, my name is Jeff Lentz. I am a postdoc in the Department of Medicine, the Division of Geriatrics and Gerontology. And I am going to be presenting on sexual and gender minority adults, older adults, or LGBTQ plus older adults. We'll go from there. So I do not have any financial disclosures. Attendees will learn the different sexual and gender minority identities, brief timeline of gay rights movement in the United States, historical events that negatively impact sexual and gender minority older adults, health disparities among sexual and gender minority older adults and their implications for practice, tips for creating welcoming, affirming, and inclusive environments for sexual and gender minority older adults, and some available resources that I put together that I found to be more lay-friendly. So like I said, we're going to go over the terminology briefly, brief history, health disparities and implications, tips for welcoming inclusive services, and resources. So first I want to go through some of the terminology. So for the sake of time, I'm going to go through the terminology a little quick. I do have links, so you can reach out to me personally, and I could send you the PowerPoint slides after the presentation, because there are links throughout the presentation with lots of good resources. So sexual and gender minority. So why do I use SGM? So SGM is consistent with NIA research. And 2, it's a little bit more inclusive because sometimes it might struggle to remember all the different LGBT, A, B, C, D, E, F, G, the alphabet. Every day research comes out, there are more identities that are being recognized. So sexual and gender minority kind of encompasses it all. So sexual minorities, right, that's sexual orientation, so that's gay, lesbian, bisexual, also includes heterosexual, right? Those are all sexual orientations. And gender identity, transgender, cisgender, there's transitioning, there's social transitioning, there's medical transitioning, surgical transitioning, and intersex. So the HRC has extensive exhaustive list, well, not exhaustive, but a pretty extensive list of the different terms available for identities. But also this Publicus Sapien resource here kind of has more, has different, not different, but lays it out pretty well. lesbian, gay, bisexual, transgender, cisgender, queer, questioning, intersex, ally, asexual, and then there's a plus category. Like I said, there are more identities being recognized each day. So again, this is a link too, so you can find out more about the different terminologies there. Other terminology, so we have the phobias. So homophobia, biphobia, transphobia, right? Homophobia is that you hate gay people, lesbians. Biphobia, you hate bisexuals. Transphobia, you hate trans individuals. Curious about the biphobia and transphobia. Within the SGM community, bi individuals do experience discrimination both inside and outside the community. So from gays and lesbians, and heterosexuals also can. And the same with transphobia. There's a lot of homophobia or transphobia from the lesbian and gay community and the outside community. And there's coming out and outing. I want to go over real quick. So coming out is a process of disclosing your sexual or gender identity. That's usually done by the person disclosing. And then there's outing is when you deliberately out someone's sexual orientation or gender identity, which is kind of negative because you kind of destroy that person's trust. Because coming out is a process throughout the life course, and gay and lesbian individuals or trans individuals, right? They come out throughout their life course. And other terminology with pronouns. So the LGBT Life Center has good pronouns, a good resource for pronouns. They're he, him, his, she, her, hers, they, them, theirs, they, them, and theirs also are used in the singular, and these, thee, and these. So those are different kinds of pronouns that are used. These are more of the most common ones. But then again, there's a link down below here that you can click on, and it'll give you more information about pronouns. This is a gender unicorn. This is done by the Trans Student Educational Resources. It's a good graph kind of showing you the different social constructs of gender identity, gender expression, your sex assigned at birth, you're physically attracted to, emotionally attracted to. And again, there's a link. This is linked as well, and it has some good information pertaining to the gender unicorn. Next, I want to go through a brief timeline of history. I'm not going to go through the whole entire timeline. It's kind of extensive. I do have 4 or 5 different sources for the timelines that you can do on your own. It can give you a pretty lengthy history of gay rights and SGM rights movements throughout the timeline. I do want to know a couple key things real quick. So in April of 1952, the American Psychiatric Association lists homosexuality as a sociopathic personality disturbance. So it classifies it as a mental illness. In April of 1953, President Eisenhower signs an executive order that bans SGM people from federal government because they think they're a security risk. So along the same lines as the Red Scare with communists in government, McCarthyism, the Lavender Scare came about. In 1969, in June of 1969, the police raided Stonewall, sparking the gay rights movement in New York. In December of '73, the APA does remove homosexuality and mental disorders in the DSM-2. That's the Diagnostic Statistical Manual of Mental Disorders. In the 1980s, HIV/AIDS was referred to as a gay disease or gay-related immunodeficiency disorder, which is, it doesn't just affect SGM individuals, but it was labeled a gay disease. In '93, President Clinton signed Don't Ask, Don't Tell into law. So if you did reveal your sexual identity or gender identity to in the military or active duty, you were dishonorably discharged, which came with a slew of other negative consequences. In '96, President Clinton also signed the Defense of Marriage Act into law, which defined marriage between one man and one woman. In 2011, Don't Ask, Don't Tell was repealed, and in 2013, the court, U.S. v. Windsor, strikes down Section 3 of DOMA, so legally married same-sex couples are entitled to the federal benefits. So I have 3 different sources that you could review here for more information on the timeline. And this current administration, the Biden administration, he signed an executive order advancing equality for LGBTQI+ individuals. This strengthens supports. This specific section of the executive order is supports for LGBTQI+ older adults, right? So this is more like non-discrimination protection, developing and publishing a document parallel to the guidance required of subsection A, the Bill of Rights for SGM older adults. Also support considerations for issues, declaring them as greatest social need under the Older Americans Act, and considering ways to improve and increase appropriate data collection. I'm going to talk about data collection later on for sexual orientation or gender identity, SOGI data. And again, the executive order is linked, and so is the meeting agenda. But key discriminatory practices, so this will impact your older adult patients, residents, right? There's anti-cross-dressing laws, right? Anti-cross-dressing laws. So if you dressed up as the opposite gender in the past, you could be arrested. And then now we're seeing all this past anti-gay legislation come back into the future, primarily by the Republican Party, with anti-drag laws or sexual and gender minority anti-sexual and gender minority bills. Pre-1973, if you disclose your SOGI identity, your sexual orientation or gender identity, you could be institutionalized. So if you went up to a nurse and you say that you were gay, you could be potentially put into a mental institution. They experienced castration, hysterectomies, and lobotomies. They went through electroshock therapy and inversion or conversion therapy. There's inversion therapy, conversion therapy, which still does happen today, but there are some states that did outlaw that, where that means they're trying to change your sexual orientation back to straight or your gender identity back to cisgender. And of course, the Lavender Scare. So all these historical events, and there's more links down here for more information on those, impact their help-seeking behaviors, where they have a distrust in the system and across these different institutions. So in Georgia right now, there are 5 bills, and I believe one did pass into law, SB 140, which prohibits treating gender dysphoria in minors by hospitals and licensed healthcare facilities. So this prohibits certain surgical procedures. It's very rare that there are any surgical procedures done on minors. A lot of it is counseling. But that's gender affirming care. So basically they're trying to erase trans individuals from history. And this impact, we want to start looking at these bills now because this will impact that generation when they grow older. We have HB 653, which prohibits healthcare providers from performing gender affirming care on minors. And in gender affirming care is a lot of different things. From counseling to puberty blockers. SB 180 is the Georgia Religious Freedom Restoration Act, which gives them a license to discriminate based on your religious beliefs. And then there's SB 141, which prohibits healthcare from performing specific tasks on minors related to their gender appearance. And then the SB 88, which is the Parent and Children Protection Act of 2023, which is similar to Florida's Don't Say Gay bill. Those are the 5 bills right now that I'm aware of. This is current as on the ACLU site that do impact SGM minors, but that will ultimately impact them throughout their life course. So as they grow older. So I want to go through some health disparities related to among older SGM adults. So first off, SGM older adults are a hidden population, right? There are approximately 1.4 to 3.8 million SGM adults over 65, and by 2030, they're expected to reach 3.6 to 7.2 million. But there's no really definite number. As you can see, there's a big wide range because there's a lack of SOGI data, so sexual orientation and gender identity data. So there recently in the NHIS survey, so the National Health Interview Survey, 2013 started collecting sexual orientation, and 2018 started gender identity. The Health and Retirement Survey, HRS, 2016 added sexual orientation. The General Social Survey, GSS, captured SOGI in 2016. These are some common data sets that a lot of health researchers use. There's no specific question on the US Census, but one can match by same-sex partner. So there is a significant need to capture SOGI data in your research or on intake forms in order for us to understand how the aging and health process is for sexual and gender minority older adults. So again, there's trouble finding participants for research studies, right? So while there is a growing interest in studying older SGM adults, there is much unknown. So there's a dearth of research involving SGM older adults and finding participants, especially SGM of color, SGM older adults of color, right? Because there's that intersectionality. SGMs belong to multiple groups. There's double jeopardy where, you know, if you're an SGM of color, you're experiencing racism, but you're also experiencing homophobia. And that just gets worse as you pile on other identities. So if you have a disability, right? If you have a chronic condition, if you're overweight, if you're a veteran, right? All those different identities make it a little bit more complex for you to navigate different social institutions. And the same with older trans individuals. So most sexual and gender minority research centers on affluent, educated white gay men and lesbians, which is unfortunate because you can't really generalize or apply those different outcomes or disparities to SGM older adults of color or SGM or trans older adults. Okay, so from a social context, there's heteronormativity within our society. Heteronormativity basically prioritizes heterosexuality, right? That's the default sexual orientation. So when you're going into, you know, an assisted living community or a hospital or an ER, when you're going in there, it's automatically assumed you're straight, right? Or it's automatically assumed that your gender, right? And then there's ageism within the SGM community, right? And what does that mean? That means the SGM community is very ageist against older SGM adults. Our society, it matches our society, where our society is also ageist. There's a reduced access to community support, the lack of relationships with family of origin, right? And family of origin means that's your biological family or your adopted family, right? There's an over-reliance on families of choice, which is like friendships that you build that become family. SGM older adults disproportionately live in urban centers, single, live alone, and without children. So they're 2 times as likely to be single and live alone, and 4 times as likely to, less likely to have children. SGM adults, older adults, are more likely to face discrimination, social stigma, and the effects of prejudice, and this happens over time. Face poverty, face homelessness. They have overall poorer physical and mental health outcomes, and they're more likely to use long-term care services. They experience discrimination, right? So they came of age during a horrific time in history, right? You could be arrested, fired, or worse, murdered, right? They experience discrimination has been condoned, right? So with like the lavender scare, for example, that was condoned. The South and the Midwest are the two most dangerous areas for SGM people, period. Same for older adults. They're very heavily religious, so that plays a role, and that's condoned, right? 82% report having at least one instance of victimization. About 2/3 experience victimization at least 3 times during their lives, like employment, housing, for example. More than half reported being discriminated against in employment or housing. They've received inferior, neglectful health care or have been denied health care altogether, right? So geographical location. So one of the first things I learned when I moved down here, because I identify as a gay man, is ITP and OTP. So 285 goes around Atlanta. ITP is inside 285 and OTP is outside of 285. So ITP is more safe, is safer for marginalized groups in general, you know, but there are areas and pockets in that where they're not. But generally speaking, inside the perimeter, ITP is safe for us versus outside of the perimeter, North Georgia, South Georgia, especially. So that also plays a role. So the long-term negative outcomes, the lifetime discrimination is associated with higher odds of disability, which is one of the findings in my dissertation. I did find lifetime discrimination does have a higher odds, or is associated with a higher odds of disability, which is quite alarming. There's financial security, right? There's a lack of financial security, right? Discrimination, again, negative impacts on education, employment, housing, stability, right? All this decreases your financial stability. So this is your potential accumulation of wealth. So not being hired because you're gay, being fired because you're gay, being treated differently, bullied in school because you're gay, or in college, or in a doctoral program, or in a residency, right? SGM people are poorer and have fewer financial resources compared to their heterosexual counterparts. SGM people are more likely to experience employment discrimination, which ultimately impacts their lower earnings and Social Security payments. Approximately 1/3 of SGM older adults live at or below 200% of the federal poverty line. And this is worse for SGM people of color, but it's worse for trans individuals as well. So trans people are more than 2 times as likely to live in poverty compared to non-trans, and trans people of color are 3 times as likely. There's a reliance on the families of choice. So caregiving is a unique issue in the SGM community, especially older adults. So 21% of older SGM people provide care to friends compared to 6% of non-SGM older adults. They become caregivers at higher rates. 54% older SGM care recipients receive help from their partner, and while 24% care from a friend. And they're more likely to care in isolation, right? And this is problematic. It exacerbates stress, caregiver burden, social isolation, right? And this leads to caregiver burnout and ultimately other negative physical and mental health outcomes. So there is a major concern of older SGM individuals disclosing their identity to healthcare providers, and this is especially higher for bisexual and gender diverse people. Discrimination, hostility, and poor treatment because of identity is what they experience. And this is especially concerning for SGM people of color. So the impact is delaying help, right? Reluctance to seek help, right? Things will get worse. So instead of going to see your general practitioner, you're going to go right to the ER, right? So you're going to end up, one, spending more money going to the ER compared to going to your general practitioner. But also you're waiting until things go worse so you can potentially find more issues and cost more money, right? But this is because fear of rejection, neglect, and other humiliation. There is a lack of confidence that mental health, social care, and support services will understand and meet their needs. SGM older adults are less likely to reach out to senior centers, meal programs, and other services because of decades of discrimination and harassment. Most of them think they're unwelcome. So later in the presentation, I'm going to share tips on how to make your practices LGBTQ welcoming and friendly. Right, there's delaying and avoiding medical care because fear of discrimination and mistreatment. 1 in 4 trans older adults report having to teach their healthcare providers about trans-related issues to receive appropriate care. At the end, in the resources section, Dr. Merck kindly forwarded me an article from her colleague, Dr. Petit, I believe, and colleagues about trans care. That'll be helpful to clinicians. 88% of older SGM people feel comfortable seeking long-term care services only if staff were trained adequately to help with SGM-specific needs. And we do have allies and groups, right, develop diversity training and educational materials, kind of like my lecture today, to improve quality of care. You improve quality of care, you have better health outcomes. SGM people in general, and adults also experience minority stress. This is discrimination. It can be lifetime discrimination. It can be acute discrimination, prejudice, internalized stigma, and concealment, disclosure of their identity. All these combination have a negative impact on mental and physical health. So there's higher rates of poorer health, physical and mental distress. 41% in this survey from SAID found that SGM adults have a disability compared to 35% of heterosexual older adults. 23% of older trans adults avoided going to the doctor because they feared being mistreated, and 33% didn't go because they couldn't afford it. So that's very concerning, especially doing outreach to communities. So there's an increased likelihood of chronic conditions and limitations with ADLs, activities of daily living, and instrumental activities for daily living. Worse self-rated health, engagement, and risky behaviors, so substance misuse, so smoking and drinking, binge drinking, for example. There's an increased likelihood of living with HIV, right, including late-stage HIV diagnosis, right, and this is late-stage has a greater risk of complications, risk of accelerated aging after HIV infection, right? Not seeking help because you are, one, embarrassed. So having an HIV, being HIV positive or AIDS, that's a stigma within itself. And then add the stigma of identifying as a sexual gender minority, and then add another category, right? If you're of color or if you have a disability, for example, right? Well, that creates different experiences. On the flip note, SGM older adults do engage in exercise and preventative care, so they go and seek out getting HIV tested, prostate, breast cancer screenings, prostate cancer screenings. For my research, I study older SGM adults with disabilities. So I look at chronic conditions and disabilities, and my co-author and I have just put together a poster for the ACRM conference in Atlanta, the American Congress on Rehabilitative Medicine. So we found in our data set, 91% of SGMs reported having a chronic condition. That's a lot, with an average of 3.2, which is also a lot. 20.6 of SGMs in this data set reported having a disability, which is a pretty good chunk, right? So it's 20% of the data set. So 4.3 of that 20% had an ADL only, 71% had an IADL only, and 24.5% had both an ADL and IADL. So for nearly all chronic conditions, SGM people 50 plus were more likely to experience disability, and the strongest associations were multiple sclerosis, stroke, AIDS, heart failure, and heart attack. HIV and AIDS, right? This proportionally impacts SGM people, including older SGM people, right? Living longer due to medical advances, more use of protection, and medical medicine. 17% of new cases were diagnosed people 50 plus, which is a pretty high rate. Estimated about 50% of Americans living with HIV are over 50. And it's estimated that 50% of patients with HIV have an HIV-associated neurocognitive disorder, right? Developing dementia, for example, impacts memory, motor skills, cognitive functioning, right? This leads to depression, psychological distress, Alzheimer's disease, right? Disability, so on and so forth. So there are high rates of mental illness for SGM people, older adults. We're more likely to have a diagnosis of depression and anxiety. We found that depression and anxiety is associated with disability. So there are concerns over mental health among SGM individuals experiencing minority stress, right? However, they are resilient. So they have empathy and compassion to past experiences of stigma and discrimination. So that makes them unique. So I did find that the other measures of minority stress, like victimization, outness, and internalized stigma, had no impact on disability in my dissertation because of resilience was a buffer effect. They also had higher education, they made higher incomes, so all that buffered the impact, with the exception of lifetime discrimination. And I did mention ADRD, so Alzheimer's disease and related dementias, right? Depression, obesity, substance use and misuse, lower rates of preventative screening, cardiovascular disease, HIV and AIDS. Those are all risk factors for dementia, and there are a higher prevalence for SGM people individuals. So we're going to see more and more SGM individuals become diagnosed with dementia and related dementias, right? So about 7.4 live with dementia right now. Unique challenges for people, for SGM older adults living with ADRD, 40% say their support networks decrease over time. 34% live alone, and up to 30% have lower rates of care. 51% say they are concerned about having enough money, right? So I talked about the financial stability aspect of it, right? Dementia and the increased use of using long-term care services, right? That is, those could be very expensive. 40% say their healthcare provider don't know their SOGI, their sexual orientation or gender identity. And now I have more information you can click here, right? And everything has a link to it again. So another unique challenge is the potential loss of identity, right? It's even more complex, you know, when you're estranged from your family, but they're still living, and you develop a disability or you become unable to take care of yourself. They come out of the woodwork. They just do. So when your family of origin comes out of the woodwork, right, there might be some recloseting because you're embarrassed that you are out. Recloseting means going back in the closet, and that actually happens a lot in long-term care communities, like assisted living communities, personal care homes, where older SGM individuals go back in the closet or are very selective about disclosing or decloseting, coming out of the closet. And then with trans individuals, there's detransitioning, right? There's just not enough research related to older trans individuals, especially in ADRD realm, about memory problems and cognitive issues. There's emotional strain, stigma, and social isolation associated with caring for ADRD, right? Lack of access to care, and then financial insecurity. Social isolation, so older SGM people are vulnerable to social isolation, right? Because they live alone and have smaller social networks. In this stage study, 59% of older SGM people report feeling a lack of companionship. 53 reports feeling isolated from others. And then loneliness and isolation lead to poor physical and mental health. So prolonged isolation, there's a risk of smoking 15 cigarettes a day, for example. Wellness affects health outcomes and encompasses positive habits, right? So if you are around positive people and you have people who are exercising, eating healthier, right, you're more likely to do that. So physical activity, abstaining from substance use and misuse, receiving regular checkups. So if you have that support network, a partner who's very positive, or your group of friends is very positive, does physical activity, gets their checkups regularly, you know, you're more likely to do that. The reverse is the same. If you're around negative people and they're, you know, binge eating, binge drinking, engaging in substance misuse, not going to the doctor, you're more likely to experience that. And then there's a negative impact, right? Minority stress has a negative impact on overall health. About 1 in 3 SGM people smoke, so that's 50% higher than the general population. That's, you know, comes with cancer, comes with other COPD, other chronic conditions. Sexual minority older people are significantly more likely to drink excessively than heterosexuals, and trans older people are more likely than their non-trans peers to drink excessively. 39% of SGM older adults have had suicidal thoughts. 2 out of every 5 trans have attempted suicide in their lifetime. There's a housing concern, right? There's a general concern of older SGM individuals using long-term care services like assisted living communities, personal care homes, going to respite care, using senior centers, going to the hospital, using hospice, because of the fear of discrimination, the lack of cultural competency. So this is a major concern among SGM older adults. So there's bias and discrimination, which negatively impacts safety. There's affordability. All this is not conducive to aging well and in place. There's an increased long-term care services in hospitals. 48% of same-sex couples experience adverse treatment when seeking senior housing. 23% of trans individuals reported having experienced some form of housing discrimination in the past year across 10 different states. There are 21 states and 5 territories have no explicit laws prohibiting housing discrimination based on your sexual orientation or gender identity. So all this is to say that we want to make our care environments more welcoming, more inclusive to older SGM adults due to their unique histories and life courses, the lifespan experiences. All these negative health outcomes, health disparities impact them and make things worse. So we want to start with inclusive and affirming care. So this is a real quick review. I do this in my sociology 101 course, in my human service courses I teach. I start with the addressing model. So this looks at age, any type of disability, either developmental, born with, or acquired later in life, your religion, your ethnicity and race, your socioeconomic status, your sexual orientation, your indigenous heritage, national origin, gender identity, gender, all the different social categories that make us a person. We look at how all those, plus our social locations and worldviews, where we're from, our geographical location, where we live in the country, our culture, right? We look at all that and how that impacts our worldviews and what we know about SGM older adults, where you stand, right? And then I just kindly remind them to look at their codes of ethics and make sure you're culturally competent, working with marginalized groups, such as older SGM older adults. So know your biases, both implicit and explicit, your competencies, because you want to give competent, respectful care. And again, that's linked for you. So these are 5 different sources that I'm going to be like pulling from for the this part of the presentation. There's standards of care for transgender and gender diverse people, which is Dr. Poteet et al. That's the one Dr. Merck sent me. And then Bailey et al. Has Equal but Different, Improving Care for LGBT plus older adults. There's a lot of good information in there. And then LGBT inclusive hospice and palliative care and welcoming LGBT residents for senior living staff. A lot of this stuff could be used across different care. The same with inclusive services for older adults. And there's a link for everything on here. So, right, cultural awareness is the first step, your knowledge. That's definitions, history, culture, experience, aging issues, health disparities, identifying evidence-based practices, which we kind of already went through. Cultural humility, the next step is to look at your attitude. Are you supportive? Are you confidential? Are you making no assumptions? Are you understanding? Are you providing good service? Are you being respectful, right? Are you honoring the individual's perspective as an expert in their own life? Right, those attitudes go a long way. And then responsiveness, so that's your behavior. What are you going to do, right? Are you going to do inclusive practices? Are you going to be engaging in respectful advocacy? Are you going to build trust, build community, right? Are you going to make a safe culture and environment, right? Are you going to be committed to outreach, going to trainings, being more effective, right? Are you going to embrace diversity in all aspects of business, taking a systems approach? You know, having a non-discrimination statement is a pretty good start, right? So we care for everyone, regardless of ability to pay, race, ethnicity, disability, color, religion, age, gender identity, gender expression, sexual orientation, and so on, right? Veteran status, right? You want to be explicit to include gender identity, sexual orientation, and gender expression in that. Are your SGM employees being taken care of? Are they receiving the same benefits, right? Are you treating them well, right? If your SGM employees are not being treated well or are not happy because of homophobic or heteronormative policies, then you're going to have a problem with your SGM patients, residents, clients. Intake forms, right? So I have several examples of intake forms to collect SOGI data, right? Very important to have the SOGI data, again, because we need to know what their challenges are and how to address them to make have better outcomes. What name would you like to be called? What pronouns do you use, right? What word or words would you use to describe your sexual orientation? And there's two links here for two different kinds. SGM elder adults remain an invisible population because we do not regularly collect SOGI data on intake forms and research. I'm going to harp on that and harp on that and harp on that. So here's an example from Williams Institute scholars in 2020. They did a sexual identity. So this is like if you're interviewing, administered, like, do you think of yourself as gay, lesbian, straight, that is not gay or lesbian, bisexual, something else, or you don't know the answer? And then if there's something else, you want to do a write-in because that's where we discover more identities. That's very helpful. Gender identity is usually a two-step process. There's one on your original birth certificate. What was your sex assigned as male or female? And do you describe yourself as male, female, or transgender? None of these are something else. And then making your community's engagement. So I don't know if you could see in my camera, I have a LGBTQ plus or SGM flag pin on my lanyard. That signifies, that I'm safe to be around, and I also identify as being part of the community. There's also pride stickers, pride pins, ally stickers. I know Emory University does safe zone training. Those are good to attend. Green zone training for veterans. When I worked at the University of North Georgia, we had a veteran one. We had a LGBTQ plus one. So those are some good materials, good brochures, stickers, any of that posted in your communities. And then lastly, I want to go through a couple of resources that are very good that I found that were very lay friendly for the general public, for anyone. So there's the SGM Aging Cultural Competency from SAGE. SAGE is Services and Advocacy for Gay, Lesbian, Bisexual, Transgender Elders. They're a very useful source, obviously, because they just deal with older SGM adults. And they have tons and tons of resources on their website, like cultural competency training that I have down here, from planning to action, LGBTQ plus inclusive AAA. Let's see what else I have here. National Resources Center on SGM Aging. So there's a lot of different good resources here. The National LGBT Health Education Center also has really good resources. So like affirming services for trans and gender diverse people. Longtermcare.gov is another good one. Long-term care consideration for SGM older adults. The ARC has resources for SGM community. There's SGM Aging Project from Fenway Institute, SGM Aging from Williams Institute, and the National LGBT Health and Longevity Center, the Wellness with Pride. They have some really good resources there. That's the Aging with Pride study that I used for my dissertation, the data set. And then there's Find LGBTQ plus family friendly healthcare near you. There's a link on this where you could type in what you're looking for and your zip code, and doctors or any other kind of clinician that identifies themselves as being LGBTQ friendly, or someone left a review and said that they were LGBTQ plus friendly, sorry, is also good. And then this is from Bailey et al. I shared some of their research earlier in the slides under healthcare disparities. They also pulled together a bunch of resources. So again, this is linked, and you can pull up the different resources, or you could do a Google search on any of these resources right here. So those are good to have. And then standards for care for trans and gender diverse people. Again, this is Dr. Merck sent me this article, which you can find here at Emory. And it gives you like different aspects of care, primary care, assessment of trans and gender diverse persons. There is adult patients and adolescents, mental health, medication, surgery, and then education. For the sake of time, I don't want to read each one of them, but you will have access to this. Again, this is from Bailey et al. This is some specific areas, their challenges and proposed solutions to boost health and social care services preparedness to meet the needs of older LGBT plus communities. Again, there's a concern for older adults, sexual and gender minority adults accessing services in long-term care. So one of them is cultural competency, right? And right there, all this is really good information. Non-tokenistic LGBT plus is, right, you don't want to have your tokens or practice tokenism where you just, you have your token gay person or your token older adult person. You want to be very genuine about showing your inclusiveness. And that is it. Thank you. And then feel free to email me for a copy of this presentation, or I can send it to Kia, whichever is easiest. I don't mind.
Thank you, Dr. Lentz, for such a great and comprehensive talk. Any questions? I know for data collection, how are we doing at Emory when it comes to EPIC and our computer systems about getting SGM data?
I'm trying to think, because I've gone to Emory for my own healthcare, and I think it's optional to fill it in. It's not like mandatory. It's like I think it's under what else do you want your doctor to know about you? on a questionnaire like later on. Like I had to find it. It's not like up front, but I'm not sure what the exact number is.
I know we switched from Power Chart to Epic. I know some patients will, they are allowed to change their name and have a preferred name in Epic, which is something new compared to Power Chart. But definitely, I think that's something we should work on and get more data so you can do your research.
Yes, that would be awesome.
Any other questions? I know you mentioned dementia in this age group, and you also mentioned HIV-related dementia. Is there a difference though, like versus well-controlled HIV versus uncontrolled, or even with well-controlled HIV, you seeing increased rates of dementia in these patients?
Can you repeat that?
Like HIV being well-controlled versus uncontrolled, even with well-controlled HIV, are you seeing increased rates of dementia?
I'm not 100% sure on that question. I am making a speculation here that it's on uncontrolled HIV.
Yeah, we definitely see memory and dementia even early. I'm on service now with some patients with uncontrolled, very low CD4 counts. So I was just wondering if, yeah, even with well-controlled HIV, was the dementia rates higher?
Yeah, I'm not 100% sure, but that's an interesting question. I can look more into it.
Another project for you.
Yes. Another project.
There.
Dr. Lentz, I had a question. That was a great presentation.
Thank you.
Wondering if there's any trends or epidemiological data looking at the changes in how minority stress is affecting the LGB population in the elderly, mainly because I guess I would assume there might be changes to kind of social acceptance and some of those kind of stigmas that we don't necessarily see perhaps as frequently or as intensely now than we did, you know, in the 1970s or 60s, right? And so wondering if anyone's looked at that.
Yeah, so in my dissertation, I looked at minority stress, the minority stress in the context of the disablement process model, which is my title of my dissertation. So I was looking to see if minority stress does lead to disability among SGM adults 50 plus. And what I found is that lifetime discrimination does impact disability. There's an association of greater odds. But like internalized stigma, no. Victimization, no. And outness, no. So the population that I looked at, the data set I used, the Aging with Pride data set, most of them were white, affluent, highly educated. Those right there are buffers. They also developed resilience through the life course. So we do see that some, not all, build up the resilience through the life course to buffer the effects of minority stress. And then some, right, some will experience that, right, depending on, and like SGM adults of color, there was a lack of representation in that data set for SGM adults of color. So like my results probably would have been different if we had a better representative sample. But yes, it's not determined, but it is determined. But I don't know of any specific study that's done that through the life course. A good question.
Thank you.
Any other questions? Well, I'd like to thank Dr. Lentz for being our featured speaker this year. And on behalf of the DEI Council, we would like to thank everyone for joining today. And please, anyone who's interested in joining the LGBTQ plus and ally affinity group, please reach out to myself or Kia, and we can give you information. Have a great day.
Bye. Thank you.
Thank you.